we left off with finishing off the second half of chapter 18. So we're going to start off by talking about the intrinsic system of the heart and basically how the heart allows for it to contract on its own and generate its action potentials to be delivered throughout the heart. So the heart is going to set its basic rhythm, and we call this the intrinsic conduction system. And this intrinsic conduction system is going to be the coordinated heartbeat that's a function of gap junctions that we see and find in the heart. So this conduction system is going to be a network of non-contractile cells. And remember, we collectively call these cells pacemaker cells that will initiate and distribute impulses to coordinate depolarization and contraction of the heart. So the action potential is initiated by those pacemaker cells that we were talking about in the first part of this video. So they are, they have unstable resting membrane potentials that we call the pacemaker potentials. And there's three parts of the action potential that's going to help generate them. So the pacemaker potential, which is the first step, is going to occur when potassium channels are closed, but we have slow sodium channels that are open, causing the interior to become more positive. And this is all very similar to the generation of an action potential that we talked about in AMP1 when we were talking about the nervous system. Step 2 is going to be depolarization, where we have calcium channels open when the internal environment of the cardiac muscle cells get to about negative 40 millivolts, which allows a huge influx of calcium, leading to a rising phase of the action potential. And then we have repolarization, where potassium channels open, allowing an efflux or an exiting of potassium, and the cell becomes more negative. Excuse me. So here we have a diagram showing us these three phases. So phase 1 is going to be the pacemaker potential. This is when we have a slow depolarization due to both the sodium channels and potassium channels. Due to the opening of the sodium channels and the closing of the potassium channels. The depolarization, which is going to be this rise that we see right here, is going to occur when the action potential begins, when the pacemaker potential reaches threshold, and depolarization is due to calcium influx into the cell through the calcium channels. And then phase 3, repolarization, which we find right here, is going to be due to calcium channels inactivating and potassium channels opening up. And this allows for a potassium efflux, which brings the membrane potential back to its most negative voltage. So the way that the intrinsic conduction system works is that we're going to initiate the action potentials at our pacemaker cells, more collectively or more specifically called the sinoatrial node, or the SA node. Then that electrical impulse is going to travel to the atrioventricular node, or the AV node. Then we're going to go to the atrioventricular bundle, the right and left bundle branches, and then lastly through the Purkinje fibers. And so the pacemaker of the heart is what we call the sinoatrial node, or the SA node. And it's found in the right atrial wall. It will depolarize faster than the rest of the myocardium. So that's why we call it the pacemaker of the heart. It's going to generate about 75 impulses a minute, which is going to basically be our resting heart rate. And the impulses will spread across the atria, and then it will travel to the AV node. Now, the AV node is found in the inferior interatrial septum. Remember, that's the septum that divides our two atria. And it has a delay impulse approximately about 0.1 seconds. So the AV node can actually generate action potentials, especially if the SA node has a defect and it doesn't work. But the AV node will only generate about 40 to 50 impulses per minute if the SA node is not working. So obviously, anyone that has a heart rate around 40 40 or 50 beats per minute, that's a very, very low heart rate. It's not sustainable, but it's enough to where the heart's going to keep pumping, and in hopes that you can get to a hospital and figure out what's wrong and get the problem fixed. So we're going to generate the action potential at the SA node. It will travel to the AV node. Then it will travel to the AV bundle. And the AV bundle is located in the superior interventricular septum. Remember, that's the septum that divides our two ventricles. It's the only electrical connection between the atria and the ventricles. And then from the AV bundle, we're going to send that impulse to the right and left bundle branches. And it's going to be two pathways that are found in the interventricular septum, and it will carry impulses toward the apex of the heart, or that tip of the heart. And then lastly, those impulses will travel through the subendocardial conducting networks, which we call the Purkinje fibers. And so this is a complete pathway through the interventricular septum into the apex and the ventricular walls. It's more elaborate in terms of its network on the left side of the heart. And the AV bundle and the Purkinje fibers will depolarize about 30 beats per minute if the AV node doesn't work, which is good for us, because if the SA node doesn't work and then the AV node doesn't work, it doesn't mean that our heart's just going to automatically stop beating and we're done. We still can have some depolarization occur in the Purkinje fibers, but once again, having a heart rate of about 30 beats per minute is not sustainable, but it's going to keep you alive in hopes that you can get to a hospital and figure out what's wrong. So here we have a diagram showing us the intrinsic cardiac conduction system and how all of this is processed. So we're going to start at the pacemaker of the heart, which is the SA node. It will generate its action potential. It will travel through both atria and then get to the AV node. And so the SA node will generate its impulse faster than the AV node. So by the time the impulse gets to the AV node, it will inhibit it, and will not inhibit it from generating its own impulse, but there won't be a need for it. So then from the AV node, we're going to travel down the AV bundle, and then we'll travel down the right and the left bundle branches, and then through the Purkinje fibers that we see here. And like we said before, the network of Purkinje fibers is going to be more vast on the left side of the ventricles versus the right ventricle. Okay, we're going to skip on, but of course, you definitely want to study that. So modifying the basic rhythm, and this is going to talk about the extrinsic innervation of the heart. In other words, how can the nervous system and the endocrine system affect the heart? Because we know that the nervous system isn't going to generate the action potentials for the heart, but they can have an effect on the heart. So heartbeat is going to be modified by the autonomic nervous system through cardiac centers that we find in the medulla oblongata. So the cardio acceleratory center is going to send signals through the sympathetic trunk to increase both heart rate and heart force. So think of times of fight or flight, and we have an adrenaline rush. Your heart rate is going to pick up, blood is going to be pumping faster, respiration is going to pick up. So this particular center is going to be involved when we need to increase our heart rate and our heart force. So what it does is it will stimulate the SA and the AV nodes. It will also stimulate heart muscle and then the arterial supply to the heart, so that we can allow for the heart to function at a greater capacity. Versus the cardio inhibitory center is going to involve the parasympathetic nervous system. So the parasympathetic signals will communicate to the heart through the vagus nerve to decrease heart rate. And so this will inhibit the SA and the AV nodes through the vagus nerves. And this is just a diagram showing the innervation of the heart and the effects that the autonomic nervous system can have on the heart, whether it wants to accelerate the heart or inhibit heart rate. Okay, so action potentials of contractile cardiac muscle cells. I'm not going to test you on this, but I did want to explain this to you because this is going to explain why skeletal muscle cells contract so quickly, whereas our cardiac muscle cells do not contract as quickly. So we have contractile muscle fibers that make up the bulk of the heart and are responsible for its pumping actions. And so when we're looking at the action potentials that are going to cause these contractile muscles in the cardiac muscle to contract, the steps are a little bit different. So depolarization will open fast voltage gauge sodium channels. Sodium will enter the cell. We'll have a positive feedback of influx of sodium, causing the rising phase of the action potential. So the inside of our cardiac muscle cells will go from about a negative 90 millivolts to a positive 30 millivolts, generating the action potential of the heart, right? Then we go to the next step, which is going to be depolarization of sodium will also cause what we call slow calcium channels to open. So at around positive 30 millivolts, the sodium channels will close, but we have these slow calcium channels that will remain open, and it will prolong depolarization. And when you look at this on a graph, it looks like the contraction is at a plateau. So we'll have depolarization to occur and will cause an action potential to begin. And so we'll see this rise on the graph, and then you'll see this plateau occur before we repolarize. And what's happening is, in terms of what you feel, it's allowing for your heart contractions to not be so fast and so quick. Think about how quickly we need our skeletal muscles to contract. I want to talk, I want to move my hands. So I need for these action potentials to get very quickly to these muscles to tell them to contract. But do I want my heart contracting like this? Do I want my heart contracting as fast as I'm talking? No, we want the heart to contract at a very steady pace. So these slow calcium channels prolonging depolarization allows for our heart to contract at a more steady pace and not as so quickly as skeletal muscles. Okay, and that's pretty much all that is. So like I said, I wanted you to understand that. I'm not going to ask you the details of this process, but I do want you to understand that. So in terms of action potentials in skeletal muscles, they last about 1 to 2 milliseconds, which is very fast, like very fast. Whereas in cardiac muscles, it lasts about 200 milliseconds, which is still very fast. So if you think about your heart rate and how it beats, it's still going to beat pretty quickly, but it's just not beating and contracting as quickly as skeletal muscles. So in a contraction cycle of skeletal muscle, it's going to last 15 to 100 milliseconds, whereas in cardiac muscle, the contractions will last over 200 milliseconds. And like I said, the benefit of a longer action potential and contraction in cardiac muscle cells is that we have a longer refractory period between contractions, so the heart's not going to be contracting like this, but more so, it's going to allow for sustained contraction to ensure that we have proper ejection of blood from the ventricles through the systemic and the pulmonary circuit. Because if the heart were contracting so fast, that means we'd have less volume of blood pumping through the systemic circuit, pulmonary circuits, which means not adequate amounts of oxygen. And of course, we know if we don't have adequate amounts of oxygen flowing through our body, then we're going to have all other types of complications to occur. This diagram is just showing us the phases of contractile muscles and cardiac muscles. And we see, like I said before, this is going to be this plateau phase that we were talking about here that allows for cardiac muscle to contract at a slower pace than skeletal muscles. Okay. So how can we look at the heart, measure the heart, and see if it's pumping normally or abnormally? And we use this device called an electrocardiograph. This is going to be a piece of technology that can detect electrical currents that are generated by the heart. An electrocardiogram, or EKG or ECG, is going to be a graphic recording of this activity, and it's going to show us all of the action potentials at a given time as we're measuring heart rate and heart contraction. So when you're looking at an EKG, it's not going to trace just a single action potential. It's going to show all of the action potentials and show how the heart is beating. Electrodes are going to be placed at various points on the body to measure voltage differences. And whenever you're doing an ECG, you're going to typically see about 12 of them. So the main features of an electrocardiograph is going to be a P wave, QRS complex, T wave, PR interval, ST segment, and then the QT interval. So the P wave is going to show us depolarization of the SA node and the atria. So that P wave obviously is going to be very important for us to see, is the heart depolarizing as it should? The QRS complex is going to be showing us ventricular depolarization and atrial repolarization. The T wave is going to just show us ventricular repolarization. The PR interval is going to be the beginning of atrial excitation to the beginning of ventricular excitation. The ST segment is going to involve the entire ventricular myocardium depolarized, and then the QT interval is going to show us the beginning of ventricular depolarization through ventricular repolarization. So here we have a diagram showing a gentleman with the skin electrodes placed on him so that we can record his ECG. And then here we have a diagram showing us the electrocardiogram or ECG reading. So when you're looking at it, we see that our P wave is here. Remember, this is going to show us atrial depolarization. Then here we have our QRS complex. This is going to be the PR interval. This is the ST interval, and then this is going to be our T wave. And then from the Q to the T, this is what we call our QT interval. So when a physician is reading an EKG or ECG, they're wanting to make sure that they're seeing proper levels of each one of these waves to determine if the heart is functioning and producing action potentials as it should, or if the heart is beating abnormal. So here's a sequence of depolarization. I'm not going to go through these steps in details, so don't worry about having to memorize this flow as you see it here. But I do want you to know the different waves that we do see on an ECG and what they mean. That I do want you to know. So here we have a diagram showing us what a normal ECG looks like. So we can see very clearly our P waves. Here, let's go here. Here very clearly our P waves, QRS complex. We see our T wave here, and then we're able to easily measure the P to R intervals, the Q to T, and so on. So this is a normal ECG trace. Here we see an abnormal one. So this is what we might see when the SA node is non-functional, and we call this a junctional rhythm. And you do want to know these terms. So when you're looking at this, you'll notice that there's no P wave, and the AV node paces the heart at about 40 to 60 beats per minute. I'm not going to have the diagrams on the test, but I do want you to know what these abnormalities are and what causes them. The second degree heart block occurs when the AV node fails to conduct some of the SA node impulses. So as a result, there are more P waves than the QRS waves. In ventricular fibrillation, this is when the electrical activity is disorganized. So there is no functional pattern at all. We just see action potentials that are occurring randomly throughout the ventricles. This is a common or a more common type of ECG abnormality that most of us are pretty familiar with. And of course, this is going to be very harmful to the body, even potentially fatal, depending on the severity of it. We do see this in acute heart attacks or after an electrical shock. So this is what we would see if a person experienced either one of these. Okay, moving on to the mechanical events of the heart. So this is going to be talking about the cardiac cycle. And two terms that we refer to when we are talking about the cardiac cycle is going to be systole, which is going to be a period of heart contraction, and diastole. I always want to say that word differently, and I have to always remind myself, diastole. This is a period of heart relaxation. So the cardiac cycle is going to involve blood flow through the heart during one complete heartbeat. So one entire lub dub is what we're referring to as the cardiac cycle. Atrial systole and diastole are followed by ventricular systole and diastole. The cycle is going to represent a series of pressure and blood volume changes, and the mechanical events follow and electrical events that we see on the ECG. So there's three phases of the cardiac cycle, following the left side and starting with total relaxation. So we'll go through each one of these phases. I do want you to know these phases. I want you to know them more generally than specifically. Okay, so let's get into it. So we'll start off with ventricular filling, our ventricles filling with blood. And this is going to occur around mid to late relaxation of the heart. So pressure is low, which is going to allow the ventricles to start to passively fill. About 80% of blood will passively flow from the atria through open AV valves into the ventricles from the atria. Remember that whenever the ventricles are filling with blood, our semilunar valves are going to be closed. So atrial depolarization will trigger atrial contraction, which is going to be our P wave. The atrial will contract and then push the remaining 20% of blood into the ventricles. So the end diastolic volume, or the EDV, is going to be the volume of blood in each ventricle at the end of ventricular diastole. So when the ventricles are fully relaxed, the EDV is going to be the total volume of blood that they are able to hold. So depolarization will spread through the ventricles, which is going to be our QRS wave, and the atrial will finish contracting and return to diastole, or relaxation, when the ventricles begin to contract, systole. So ventricles contract, they're going to eject the blood through both of their semilunar valves, and this is at the isovolumetric contraction. So atria relax, ventricles begin to contract. The rising ventricular pressure causes our AV valves to close. Remember, we don't want a backflow of blood. And the volumetric contraction phase is a split-second period when ventricles are completely closed and all valves are closed, both the AV valves and the semilunar valves. The volumes remain constant and ventricles will continue to contract. So when the ventricular pressure exceeds pressure in the large arteries, the semilunar valves will both be forced open and blood will flow from the ventricles through the semilunar valves to either the pulmonary trunk or the aorta. Isovolumetric relaxation is what we refer to as early diastole, and this is following ventricular repolarization, or that T wave, after the QRS wave. This occurs when the ventricles are relaxed. And we say the end systolic volume is going to be the volume of blood remaining in each ventricle after ventricular systole or ventricular contractions. The ventricular pressure will drop, causing a backflow of blood from the aorta and the pulmonary trunk that will cause the semilunar valves to close. And then the ventricles are completely closed chambers momentarily, which we refer to as isovolumetric relaxation phase. So closure of the aortic valves raises the aortic pressure as backflow rebounds off of the closed valve cups. We refer to this as the dicrotic notch. The atria will continue to fill during ventricular systole, and when atrial pressure exceeds ventricular pressures, the AV valves will open and the cycle will begin again. So the normal heart beats around 70 times beats per minute. The cardiac cycle lasts only about 0.8 seconds, so less than 1 second. Atrial systole will last about 0.1 second, and ventricular systole will last about 0.3 seconds. The quiescent period is total heart relaxation that lasts about 0.4 seconds. So there's a very short period of time when the entire heart is not contracting and it's totally relaxed. And that's what we're calling that quiescent period, where the entire heart is at a relaxation phase. There's no beating of the heart. All valves are closed. That's what we're referring to when we're talking about this particular period. Okay, so heart sounds. So we have two sounds that we hear when we are osculating the heart, lub, dub. The first sound, lub, is going to refer to the AV valves closing at the beginning of ventricular systole, at the beginning of the ventricles contracting. And the second sound, dub, is what we hear when we hear the two semilunar valves closing at the beginning of ventricular diastole. The pause between the lub dubs indicates that the heart is relaxing. So we hear lub dub, and that very split second between the lub and the dub is what we are, is when the total heart is relaxed and there's no contracting, there's no flowing of blood, and all valves are closed. The mitral valve or the bicuspid valve closes slightly before the tricuspid valve, and the aortic semilunar valve closes slightly before the pulmonary semilunar valve. So this difference allows for oscillation of each valve with a stethoscope, and this is why your doctor would typically place its stethoscope in 4 different areas to fully hear each one of these valves and how they're closing and what they sound like. So this is a diagram showing us the areas of the thoracic surface where the sounds of the individual valves are most heard clearly. So if you've ever paid attention to your doctor listening to your heart, you'll notice that they'll probably place the stethoscope in these areas to get a good hearing of these valves, especially if they're trying to listen for defects or things like that. Okay, like I said before, we're going to skip over this, but I definitely do want you to read over this because I've mentioned it, I think, in the previous video. So definitely read over this. All right, regulations of pumping. So cardiac output is going to involve the amount of blood pumped out of each ventricle every minute, or I should say in 1 minute. The cardiac output is going to equal the heart rate times the stroke volume. So if we're trying to mathematically compute what the cardiac output is, we're going to measure the stroke volume and the heart and multiply that times the heart rate. The stroke volume is going to be the amount of blood pumped out of one ventricle with each beat, and this correlates with force of contraction. So at rest, the cardiac output should equal heart rate times stroke volume. The stroke volume should be roughly about 70 milliliters per beat, and the heart rate should be about 75 beats per minute. So in total, the average cardiac output at rest should be about 5.25 liters per minute. The maximal cardiac output is 4 to 5 times what your resting cardiac output would be in a person that's not an athlete. So that's usually around 20 to 25 liters per minute. The maximal cardiac output may reach up to 35 liters per minute if you are a trained athlete. The cardiac reserve is going to be the difference between your resting and your maximal cardiac output. And the cardiac output will change, either increase or decrease, if either both or one of the stroke volumes or heart rate is changed. So factors that can affect your cardiac output can be differences that we see between the stroke volume and your heart rate. So this leads us into this diagram here that gives us an overview of factors that are involved in determining your cardiac output. So for instance, if you're exercising, of course, that's going to increase your cardiac output because you're going to increase your heart rate. You're also going to increase your stroke volume. If you were taking or experiencing an adrenaline rush, that's going to increase your cardiac output because you're going to increase your heart rate, stroke volume, and so on. If we have changes in the autonomic nervous system, so let's say you're afraid or you're anxious or things like that, that all is going to work to increase potentially heart rate and increase stroke volume. More specifically, the changes in the autonomic nervous system, that's going to affect your heart rate more. Exercise, ventricular filling, and an adrenaline rush and hormones, that would affect your stroke volume more. And so both of these factors together are going to increase your cardiac output. For this section, I more so want you to know how we compute the cardiac output. So I want you to know it's going to be computed by multiplying heart rate times stroke volume. I want you to know what the stroke volume is, and then these factors that can increase or decrease your cardiac output. I'm not going to actually have you do the math of this, so don't worry about having to do that. And I'm not going to go into detail of the regulation of the stroke volume, so I'm going to skip over this as well. And the regulation of heart rate, I'm not going to go into details with that. Okay, homeostatic imbalances, definitely want you to read over these, know what they are and how they affect the body. Okay, so regulation of heart rate. I do want to talk about this. Some factors that will influence your heart rate in most cases in terms of increasing or decreasing it can be age, gender, exercise, and body temperature. So in terms of age, a fetus is going to have the fastest heart rate, and then as we age, that heart rate will decline. I remember when I would go to the doctor when I was pregnant with both of my daughters, their heart rates, especially like in the beginning of my pregnancy, would always be like around like 160 a minute, or maybe even a little higher. And then over the years, as they've grown up, and then I look at myself, my heart rate obviously has declined and will continue to decline as we age. In terms of gender, females have a faster heart rate than males. In terms of exercising, of course, that's going to help to increase your heart rate. And trained athletes will have a slower heart rate, meaning that if, let's say, you're a runner and you start running, initially your heart rate is going to be higher because your heart has not been trained to work at that capacity and keep its heart rate steady. But if you were to continue to run and really fine tune your running skills and your breathing, you could run at a faster rate with a slower heart rate, which is ideal. You don't want your heart rate to be, over 200 every time you run, because that's just too much exertion on the heart and causing the heart to work too much. And then body temperature, increased body temperature will increase your heart rate as well, versus decreased body temperature will decrease the heart rate. Tachycardia is going to be an abnormally fast heart rate, and this occurs when the heart is beating more than 100 times per minute. If this were to persist, this can lead to ventricular fibrillation, which is very harmful. Bradycardia occurs when the heart is beating abnormally slow, and if the heart is beating 60 beats per minute or slower, that's when we say that the heart is in this state. This may result in grossly inadequate blood circulation in non-athletes, and it may be desirable, though, for an endurance trainer. So if you're not an athlete, we don't want the heart beating this slow, because this could imply that the body's not getting adequate amounts of blood and oxygen and things like that. But if you're an athlete and you're more specifically involved in endurance training, this might be okay for you, because it's allowing your body to work efficiently, but still allowing you to not have your heart overworked. So depending on your athletic ability will determine if you having a heart rate of 60 beats per minute or maybe a little lower is healthy or not. Okay, and then I did want to discuss these two, but I'm going to skip over these conditions. Like I said, I definitely want you to study these on your own term, but I'm trying to keep these videos shorter than longer. All right, and then developmental aspects of the heart. So the human heart is going to be derived from the mesoderm. Remember that when an embryo is developing, it's going to divide into 3 germ layers. The ectoderm, mesoderm, and endoderm. So the heart is going to form from that mesoderm layer, and it begins as 2 endothelial chambers that will fuse to form a single actively pumped chamber by day 22 of gestation. Then the tube develops that will form 4 bulges that will represent the early chambers. And I'm not going to ask you in details of this, but we're just talking about it to have an understanding. So here we see the development of the human heart. So around day 20, we have these endothelial tubes that will begin to fuse together we see around day 22, the heart starts to pump. So when you think about day 22, that's just shy of 4 weeks of gestation, or a woman being 4 weeks pregnant. And around that time, it's, in most cases, you can't really hear the heartbeat with the technology that we have. You typically are able to hear the heartbeat around 5 to 6 weeks of gestation, but the heart does start beating at day 22. Around day 24, the heart continues to bend and elongate, and by day 28, we have this continuous bending of the heart so that we can start to form the four chambers. And then by day 35, the heart is completed, and we see our distinctive 4 chambers there, and the further development of the heart. Okay. All right. Developmental aspects of the heart in terms of aging. So regular exercise can keep the heart healthy and prolong heart viability. And some changes that occur as we age that can be quite natural. When I say natural, I'm meaning even in a person who has a healthy diet, they exercise, these changes can occur just kind of naturally. So sclerosis and thickening of the valve flaps can occur that will lead to heart murmurs. If the valves become thicker, they may not open and close as they should, so that could allow for some backflow of blood to occur. We can have a decline in our cardiac reserve, so that means that the heart could become less efficient and not pump properly. We could have fibrosis of cardiac muscle cells that will lead to the stiffening of the heart. So this can cause arrhythmias because the heart's not able to contract as it should, and also allow for the stimulation of those action potentials as it should. And then atherosclerosis can develop as we age. And this one, more specifically, is more so diet related. So if I am eating a healthy diet, I'm trying to consume low levels of bad cholesterol or fatty foods, and I'm very conscious of what I'm eating, then I probably won't develop this type of heart issue. But if I do have a pretty unhealthy diet, and of course this is over prolonged periods of time, this could be a consequence of that unhealthy diet. And that is it. I hope this was helpful to you. And like I said in the previous video, if there was anything in this video that I talked about that you need more understanding to, just let me know. Send me an email. We can set up a conference call or a virtual meeting so that I can bring some clarification to you. And thank you for watching. And I will hopefully see you in the next video.